So, one disclaimer I would like to give is today's talk, 30 minutes is a very limited duration to cover IBD broadly. Today's talk, I am not talking about the conventional diagnosis, conventional grading, conventional treatments, and I'm focusing mainly on the modifiable lifestyle, diet, risk factors, and the adjunct treatments in functional and integrative medicine which we practice, which will improve the response you get drastically. And in no way I'm not claiming to replace conventional medicine. Many times in acute setting, acute exacerbation of IBD, steroids are required, biologicals are required, misalazine is required. So what we do in holistic medicine will definitely help in staying in remission, reducing the load of the medicines, and also avoiding escalation into biologicals. So in the last couple of years, treating about 4,000 patients, I would like to share a few lessons in decision making before I start the topic. So we have to look at the pathophysiology of IBD has an adaptive physiology gone wrong. So what I mean is inflammation is the body's natural response to some stress trigger. Like Dr. O'Brien was mentioning, our gut is reacting to the stress factor. And when that reaction continues for a long period of time, it becomes a chronic immune dysregulation in the GI mucosa. So all the molecules we're targeting today, the biologicals which we're using to suppress IL-6, TNF-alpha, all of them are alarm systems to neutralize danger in acute inflammation setting. But when that acute inflammation continues to happen, we end up with IBD. So when you look at an IBD patient, you have to think of what is the danger which the body is trying to protect. What was the trigger which the body initially tried to protect, and because of molecular mimicry, because of chronic duration of the illness, this became a persistent activation of the healing pathway, and then they ended up with the disease. So like I said, the acute setting, we need to suppress the inflammation. It's definitely important, but the healing and long-term resolution when it will happen when we identify what is triggering the response and remove the fire in the inflammation. So one more important lesson I've learned is we should not, in IBD, we should not assume a settled previous diagnosis. I have seen multiple patients with proctitis being treated with steroid enema and misalazine for a couple of months, still passing blood in stools, mucus in stools, calprotectin is high. But when a repeat sigmoidoscopy or a colonoscopy is done and you look at the biopsy, it is an amoebic, you see amoebia in the histopathology, and it is an amoebic proctitis. So as soon as you treat that with 10 days of metronidazole or even 5 days of metronidazole, the patient significantly improves and slowly gets off the medicine. So when you see the patient not responding to certain thing, it's okay to further investigate and not settle at the initial diagnosis. Even if there is a histopathological evidence before, it's okay to repeat it. And then once we make our diagnosis, we should not get fixated on the diagnosis. So and when the patient doesn't improve, you can't ignore that information and say, okay, this is my diagnosis, I'm not looking at anything else. So there are many patients who have been being treated as infective colitis uh, and their colonoscopy is normal and MRI enterography is normal. Calprotectin is slightly high, so they're being treated for infective colitis. They don't respond. As soon as you treat them with the IBD principles, they start responding. So it can happen both ways. And also in India, we have to remember tuberculosis can get misdiagnosed with IBD, and also ileitis, which is secondary to gastroenteritis, secondary to a infection, acute infection of food poisoning, can also get misdiagnosed as Crohn's. So we should not get fixated to a diagnosis, and we have to listen to the patient and then take the decision as they progress. And in integrative and functional world, we get so many tools to use. We have so many supplements, so many probiotics and adjuvant therapies. But sometimes, like Dr. Preeti was mentioning, we just have to slow down and uh, reduce our treatment also. So sometimes I've seen that there are very sensitive patients. When you over treat them with supplements, they get flare up. So you just focus on the body mind medicine, focus on reducing their sympathetic nervous system, focus on breathing exercises and meditation. That itself is significantly improves the symptoms. So we have to personalize based on the patient. So today I would like to share a case of this. I've specifically chosen this case because I have not used anything advanced in this patient. And this patient was also from a tier 2 city, not affordable for full spectrum functional diagnostics and medicine, limited financial resources, and online patient, not an in-person patient. So even in limited resources online setting, we can get significant results with remission. So this was a 54-year-old female with diagnosis of ulcerative colitis in 2007. She has been having symptoms since then, treated multiple times with hospitalization. Every flare-up has required steroids. And she came to us with chronic bloody stools, mucus discharge, pain abdomen. She was on mesalazine and azathioprine, but the symptoms were not under control. So in IFM, we give a lot of importance to the timeline. But when I initially learned functional medicine, I was getting a little impatient and not using the timeline properly. But as I progressed in practice, I realized it's an extremely important tool. Even if you have to spend more time in your initial consultation, it's worth taking the entire history of the timeline, right from the preconception history, their birth history, because IBD, although we initially believed there is a lot of genetic predisposition, today we have enough data that it's mostly epigenetic triggers in IBD than genetic predisposition. So we have to look at their microbiome influence, environmental influence from the time they were born. So how many times was the antibiotics given in childhood? How many hospital admissions did they have in childhood? How many times did they have to use microbiome disrupting medicines or situations in the childhood, and where they grew up, where what environmental toxins they had? So once you take a very detailed history and then populate it in the matrix, even this is something which takes time, but it's not just helpful for us to understand the interconnectedness of everything, but also it gives a lot of information while explaining to the patient. So the main challenge in practicing functional medicine is not just the knowledge we should gain, but also the compliance the patient has. So if the patient is not willing to change the diet, lifestyle, put an effort in working on anxiety, whatever we do, the results are limited. So for them to understand why it's all important, I think spending a little time on the matrix and explaining to them how the modifiable personal lifestyle factors are all interconnected, how the triggering events are interconnected. So when we sit and explain, okay, when did you have flare up? When you were age 37, 36, and every time the patient says, okay, I lost my mother that time, I had a anxiety attack that time, the patient can correlate, okay, the anxiety is something which we need to focus on, and the compliance will increase. And we have to take a very detailed history of food, because the main antigenic response in IBD is the food. So, and till now, like every disease, you can come to a conclusion, okay, elimination diet will work very well, or a mito diet or a low carb diet will work very well for this condition. In IBD, that consensus is still not clear. We have to personalize the diet to the patient, uh, and it depends on the trajectory of the disease, at what level the disease is in, and understanding the patient sensitivity and then planning the treatment will make a huge difference. So we have to look at the inflammatory markers like hemoglobin, WBC, ESR, CRP, and also the micronutrient markers in the patient. Because no matter what diet they eat, the absorption is compromised, the digestion is compromised. So they will end up in micronutritional deficiency, and micronutritional deficiency drives the mucosal inflammation further and delays the mucosal healing further. And her colonoscopy had pancolitis with ulcerations and loss of vascularity, and Mayo score was 9. So I would like to structure the treatment into 4 phases, where first she's already on immunomodulators, and still she has a flare up now. So we have to stabilize her. And in stabilizing, it's not just the gut, but the nervous system also, because every time she had a episode, it's always linked to anxiety. And then we focus, once the acute flare-ups are stabilized, we can focus on mucosal healing and microbiome restoration. And then along with that, we can do our adjunct treatments along with that. So as I said, this patient was an online patient, no access to the hospital I practice in. So we started with elemental diet using peptamine powder and broths, vegetable and bone broths. And then after 5 days, this is done to immediately reduce their, so the whatever they eat, because of the intestinal lining is severely inflamed, there is severe permeability of the intestinal lining, anything will exacerbate the inflammation. So using an elemental diet will be the fastest way to get them under control when they're on a flare up. And then we can slowly get into a strict elimination diet, and then go beyond that. Since elemental diet will be a compromise on nutrition, and she was already nutritionally compromised with low albumin and all the vitamins, I asked her to get a multivitamin IV at a local clinic. And then we started doing limbic system retraining online. I will talk about it in the next slides. So in the diet, what is our primary intention is to reduce the production of inflammatory markers, address the dysbiosis, increase the colonic butyrate production, and then minimize the consumption of exacerbating factors. So elemental diet is you get the best outcome of elemental diet when you do it with IV nutrition. So if the patient has set an opportunity to come to a better center, we can correct all the deficiencies initially, especially iron, and also give them omega-3 fatty acid IV therapy, along with the vitamin C and B vitamin IV therapy, while doing the elemental diet. That will quickly get them into remission in 4 to 5 days. And then after the symptoms reduce, along with the 6-food elimination diet, in my experience, having a framework of the Crohn's disease exclusion diet is good. It's not just for Crohn's, but it works for ulcerative colitis also. But you just have to understand the basic principles between them. So in ulcerative colitis, the inflammation is more in the rectum and sigmoid. So the more residue of stools, which will increase the production of bacterial metabolites you have, then the flare up will happen. So having green leafy vegetables, high fiber, initially in ulcerative colitis will flare up the patient. But in Crohn's, the inflammation can be in the small intestine. So having complex carbs, complex protein will become antigenic initially in the intestine. So having simpler carbs and simpler protein and being personalized for what intolerances patients have is an ideal way to go about in the first 6 weeks. And then after the 6 weeks, you slowly reintroduce the diversity. And then in the maintenance also, these products have to be completely avoided, whether it's Crohn's or ulcerative colitis. In both of them, the anti-inflammatory diet is a common thing, which all of us know and practice. And when you look at the evidence, the enteral elemental diet has maximum evidence for Crohn's, but like I said, for ulcerative colitis also it works. And low sulfur diet, reducing the sulfur containing proteins, works very well in ulcerative colitis because it will reduce the production of hydrogen sulfide in the colon. And when it comes to using probiotics, again, Saccharomyces boulardii has the maximum evidence in Crohn's, and VSL3, which is a broad spectrum probiotic with E. coli Nicelle 1917, has the maximum evidence in ulcerative colitis. Now, next level, you want to actively reduce the inflammation. So omega-3, like we know, is a very good anti-inflammatory substance, but we can, many times, traditional omega-3 preparation, the IBD patient also has gastritis, also has food intolerance. They don't tolerate that omega-3. So what actually works is having a specialized pro-resolvent mediators, which is part of the omega-3 breakdown, is something which is naturally secreted by the neutrophils in the resolution phase of inflammation. But nowadays, we have these products available. They are broadly called resolvins, protectants, and marescents. So these are available as capsules, which can be used if we want to use it in active flare-up patients to get immediate resolution in the inflammation. Now, ideally, like we all know, to improve the gut lining, to improve the microbial diversity, we have to focus on the diversity of fiber. But to achieve this, it takes a lot of effort, and many times you see the CRP coming down, ESR coming down, calprotectin reducing, but the patient is not tolerating diversity. They're complaining of bloating, pain abdomen, they're not comfortable tolerating food. So that is when we have to make sure there is no dysbiosis. So if this particular patient I'm sharing didn't have access and to microbiome profiling, but if you're able to do microbiome profiling of the patient, whether it's GMAP or an Indian test, usually you will see gross reduction in Faecalibacterium progenitii, and you have more of Proteobacter and Enterobacteria. This is like a core microbiome signature of the IBD patients. Along with this, you may have other pathogens which is high, like the Candida and Aspergillus, and you may have Clostridium difficile. You may have the bacteria also going high. So if we are able to do the microbiome profiling, we can fine-tune the treatment specific to that. We can use the conventional pharmaceutical and botanical antimicrobial if it is indicated, followed by biofilm disruptors, and also use the barrier repair like L-glutamine, zinc, carnosine, aloe vera, and then also include microbiome support. So the conventional treatment for dysbiosis can be done. But what you need to remember in IBD patients are you have to use everything at a smaller dose. Sometimes it can be 1/4 of the conventional dose. If you give a high dose of biofilm disruptors, that can flare up the inflammation. If you give a high dose of metronidazole or ciprofloxacin, that can flare up. Even oregano oil, berberine also can flare up the inflammation. So always remember to treat IBD dysbiosis gently and with minimum antimicrobial, and gradually progress with probiotic. And finally, if the dysbiosis is there, low FODMAP diet will make sense here. A low FODMAP diet on a long run does not have a lot of evidence in IBD. But if you feel dysbiosis, especially SIBO, bacterial overgrowth is part of the patient, then there is a scope for low FODMAP diet temporarily. So once you address the dysbiosis, the next is to improve the colonic butyrate production. So butyrate is the most studied short chain fatty acids. It is the primary energy source for the colon lining. It is the most important metabolite in the colon, which helps in the tight junction repair. It can significantly reduce the inflammatory signaling also, and it's, the benefits in the metabolic health. But when you look at how to improve butyrate naturally, the highest butyrate producer is the Faecalibacterium prodnitzi. So, and like I said, that bacteria is significantly low in IBD. So, but when you see how to naturally improve it, again, you need to bring in a lot of diversity in the fiber. So unless the dysbiosis is corrected and the patient is able to tolerate the fiber, you'll have a challenge in bringing about natural production of butyrate. So now there are synthetic forms of butyrate available as tablets. You have sodium butyrate for general use. If that's sensitive, you can use calcium magnesium butyrate. And also there's a triglyceride form of butyrate called tributylin, which you can use in sensitive patients, especially for ulcerative colitis. Now, once the patient is in a better state to tolerate variety of fiber, then we can look at what are the prebiotics we can use to improve the Faecalibacterium load in the gut. So in ulcerative colitis, FOS and inulin combination is working the best for improving butyrate production. But in Crohn's disease, inulin may flare up the dysbiosis. So that's why it's better to start with FOS and gradually introduce inulin. And lactulose is the most commonly used in hospitals. It's great because it also is a fermentable substrate, and it will also prevent constipation if hard stools are also flaring up the patient's symptoms. Now, once we get the stabilization of the patient, at the same time, we have to focus on the nervous system support. So the gut and the nervous systems doing it simultaneously will give you the maximum results. So many times patients are in a denial that stress is not affecting them. So what I'm started using in my practice is looking at HRV. In the hospital, I measure it using a device called HeartMath and use a device called Neural Check, but also teach the patient to use their smartwatches and smart devices to measure the HRV so that they have some objective data that shows that they have to work on the mind. Now, vagus nerve is what is the main parasympathetic supply to the gut. So we knew that there is cholinergic anti-inflammatory pathways which are acting from the spleen through the vagus. But now we have enough data to show that the vagus nerve is stimulating the cholinergic anti-inflammatory pathway through the gut and through the liver. So any kind of immune response can be modulated, and pro-inflammatory response can be reduced by vagus nerve stimulation. So all of us are familiar with the natural ways to stimulate vagus nerve, which is cold exposure, humming, meditation, deep breathing, and all that. But if the patient needs faster results, there is transcutaneous vagus nerve stimulation available now. I've been using this for about 1.5 years now, and we see significant improvement in HRV immediately in the hospital. And whenever they come for other therapies, also this can be used if the patient is not yet ready to more aggressive mind-body medicine interventions. Now, once that is done, then you can focus fully on the mucosal healing and the repair phase. So for this particular patient, I started her on Lactobacillus reuteri and the Bacillus clausii, Bacillus indicus with plantarum combination, and then gave her L-glutamine, aloe vera, slippery elm, zinc carnosine, along with MCT oil for the fatty acids. And vitamin D is the most important hormone and nutrient. You will hear about it again and again in all the lectures today and tomorrow. So I'll not spend too much time on that. So protein is extremely important. Initially, we'll have to introduce it as an elemental form, and then has hydrolyzed whey protein and L-glutamine can be introduced. And if there is stricture, there is evidence of using collagen also, especially in fistulas and strictures in Crohn's. Coming to the nutraceuticals, in Crohn's, there is evidence for N-acetylcysteine, vitamin C, vitamin E, selenium, and zinc, because all the micronutrient deficiencies are seen more in Crohn's than ulcerative colitis. In ulcerative colitis, there is mitochondrial impact is higher. So there is a role for coenzyme Q10, and there is role for polyphenols and flavonoids, because that is what will drive the butyrate production in the colon. And of course, vitamin D, vitamin B12, folic acid, iron, zinc, magnesium, and selenium. So these vitamins and minerals, if it is a struggle to start them orally, the best way to do it would be to give them IV micronutrients and vitamins a couple of sessions, so that they don't have to take too many tablets when they're in the healing phase of the intestinal mucosa. Once the mucosa is healed, then you can start them on tablets and they tolerate it much better. Coming to the botanicals, curcumin and boswellia have the maximum evidence, along with the slippery elm and wheatgrass juice for ulcerative colitis. But in Crohn's, we need to be careful when using herbs and anti-inflammatory at a higher dose. Sometimes that itself can cause a little irritation to the mucosa and flare up the immune response. Now, probiotics, Saccharomyces boulardii has a lot of evidence in Crohn's, and in ulcerative colitis, basically we have to improve the butyrate production. So the evidence is more for the broad spectrum. VSL3 has the maximum evidence. And then it's important to slowly introduce fiber. If we just do probiotics without prebiotics, again, it's not a long-term solution for the patient. Now, finally, there are some adjunct treatments which are slowly getting some evidence. These are not replacement to the conventional treatments, but the evidence is building up, and many practitioners is giving positive results. But for these treatments to become mainstream, it may still take a little bit of time. So in peptides, for this particular patient, once she was comfortable, I started her on BPC 157 and KPV peptide spray, and also started mind-body interventions like limbic system retraining. So limbic system retraining is a combination of different modalities where basically the amygdala of the brain is constantly stimulated, and the body's stress response is constantly activated, and the patients struggle to relax their nervous system, and every small trigger can flare up their immune system. So starting from physiological psi to doing simple breathing exercises to more advanced positive enforcement and emotional freedom technique and psychotherapy sessions. A lot of things can be done with limbic system retraining. And ozone therapy is definitely has a role, especially the therapies which have an immunomodulatory effect, like the ozone minor autohemotherapy and major autohemotherapy. At least during the phase where they are on immunomodulators, ozone therapy can be used and until they come into remission. Now, coming to peptide consideration, BPC 157 has the maximum evidence for the use in anything related to the intestinal mucosa. It is anti-inflammatory, it has angiogenesis properties, it has improves the tight junction, and it also has metabolic effect. And then when you club it with KPV, which is 3 amino acid combination, it has anti-inflammatory and wound healing properties. There are oral formulations available for it. And if it is a severe case, you can consider subcutaneous doses, but you get good results with oral formulations as well. If the patient you feel is significantly immunocompromised, then I think there's a role for thymosin alpha 1, especially when there is dysbiosis and immune compromisation. Then thymosin alpha 1 can be started first. And once the patient improves, only then you start BPC 157 and KPV. And the duration for this is basically for for 6 months, there is enough data to say we can safely use it. Beyond 6 months, it is again controversial because of the angiogenesis aspect. If there is a chance for tumor formation or cancer formation, it may help the carcinogenesis to flare up. So this is the summary of the adjunct treatment we can do. We can also use vitamin C, alpha lipoic acid, glutathione, and omega-3 fatty acid IV therapies whenever it is indicated. So this patient, after the first month, the stool frequency reduced to 3 to 4 times a day, and there was no blood in stools. And she complained of, she said there is significant improvement in energy levels. By the second and third follow-up, she became normal, and all her inflammatory markers and micronutrients became normal. So I would like to conclude this talk by saying there is a role for everything. We have to assess the patient's disease trajectory, where they are at in their disease, how willing they are to make certain changes, and then decide the therapy. It has to be highly personalized. It's very difficult to create protocol in IBD as of now. And all these things will be great adjunct to the conventional treatment. And definitely we can reduce the need for conventional treatment with all these therapies. Thank you so much. And thank you for giving me the opportunity to share this stage.